Good morning, everyone. Welcome to this morning's COVID-19 Community of Practice, brought to you from the DFCM and the Ontario College of Family Physicians. We're pleased to continue to offer these sessions and are really excited about today's session, which is going to be focusing on the COVID-19 influenza and RSV vaccines. I'll turn things over next to Dr. Mekalai Kumanan from the Ontario College of Family Physicians.
Good morning, everyone. Welcome. Really nice to have you with us today. As Ali said, we have a really informative session ahead. And I would like to just take a moment to thank both Zain and Liz for being here with us. Just a reminder as well, this is a Main Pro accredited session and details will follow. Next slide. So just moving on to our land acknowledgement, we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantin peoples. Next slide.
So I'll provide today's reflection for the land acknowledgement. And I wanted to recognize this particular success here, which is regarding Canada's first First Nations Premier of a province. So this happened quite recently and is very exciting, not only for the province of Manitoba, but for all of Canada as well. And so I think it really speaks to the fact that representation really matters, and making sure that we are creating spaces and opportunities for people to be able to work in politics and the highest levels of government and the highest levels of our own institutions is really important. But I think what's also important to recognize that happens when all of us take that on as a collective responsibility. And as you can see, there's people from all cultures and all stripes that are engaging in celebrating this victory. So I thought I'd present this as something for us to reflect on as we think about where we work, where we think about our own institutions, our own leadership roles, the spaces in which we work, and how can we all in our own spheres of work be able to open up spaces and opportunities for others to be able to thrive and to be able to bring their valued perspectives forward. So I'll leave you all with that as we move into today's session. Next slide, please. Back to you, Mekalai.
I think I spoke to this, just reminding everyone that this is a Main Pro accredited session and you'll receive more information after we finish.
Excellent, thank you. So as we said, we have a really exciting group of panelists here to present for you today. And also what's unique is we'll have a bit of a OCFP update from the president herself, from Dr. Kumanan. So looking forward to having all of these updates today in a really engaging session. And so with that, I'm going to turn things over to each speaker in turn just to introduce themselves, starting with Dr. Chagla.
Hi, everyone. Always glad to be here. So my name is Zain Chagla. I'm an infectious disease physician and associate professor at McMaster University. These are my conflicts mainly around industry-sponsored clinical trials for COVID therapeutics and education and speaking for COVID vaccines.
Excellent. Thank you. Over to you, Dr. Muggah.
Thanks so much. Really fun and good to be back on the Community of Practice with all of you. I'm Liz Muggah. I'm a family doctor in Ottawa, and I am also the senior clinical advisor for Ontario Health in primary care.
Well, we're thrilled to have you back as well. Dr. Kumanan.
Thank you. Hi, everyone. My name is Mekalai Kumanan. I'm a family doc in Cambridge. I also am currently serving as the chief of family medicine at the Cambridge Memorial Hospital and as a president of the OCFP. I do receive a stipend for both of those roles, neither of which poses a conflict for today.
And as for myself, I'm the moderator for today's session, and I'm a family physician and also division head of primary care at Trillium Health Partners in Mississauga. And I do receive an honorarium from the Ontario College of Family Physicians for moderating these sessions. That does not pose a conflict of interest, of course. Next slide. So in terms of how to participate, just a reminder for everyone that please use the Q&A function in order to ask your questions. And if you see a question that you wanted to ask that someone's already posted, rather than posting that question again, please upvote the question because as the moderator, I will ask the most upvoted questions that are the most popular. So please make sure to use that function. For the chat box, feel free to use that, but do not ask questions in the chat. It makes it very difficult for me to be able to identify them. So instead, use the chat box for networking if you want to share comments on what's going on, etc. Next slide, please. All right, so with that, we will start our panel. So I'm going to turn things over to Dr. Chagla first.
Hi again. So I have a pretty packed 20 minutes here, but I really wanted to go through a few things that seem to come up in the questions and are considerations from most primary care folks I've been chatting with or done at rounds a few times. So the COVID vaccine update and really focusing on evidence and implementation. RSV vaccine, again, evidence and considerations. Paxlovid, there were a few questions, and then a little bit around office infection control, recognizing that that has become an issue more recently. Next slide. So COVID-19 vaccines, next slide. So as many of you know, there is a revaccination campaign that's occurring. Many of you involved with this, obviously. And so the recommendations from NACI are, again, 6 months from the last vaccine or infection, whichever is later. And then the biggest groups that are kind of front of line for targeting adults 65 or older, long-term care, underlying medical conditions that put them at higher severe risk, pregnant from First Nations, Métis, and Inuit communities, racialized and other equity deserving communities, and people who provide essential community services. At least from the standpoint of the province, essential community services includes healthcare providers, and so there is a recommendation and plans to immunize healthcare providers as part of this seasonal wave as a priority. Next slide. So this is looking at the evidence around the vaccine. So similar to the prior vaccine, they looked at antibody levels after receipt of a vaccine. And so this was looking at either a monovalent, so kind of just the XBB alone, or a bivalent, so XBB plus BA.4/5 in people that had either had a prior vaccine series plus either had been prior infected or not prior infected based on serology. And, you know, the bottom line here is they actually saw benefits across all domains so that the antibody levels were increased in all groups, even if they had prior infection, but also if they did not have prior infection. The interesting thing is that, you know, an XBB vaccine actually worked to boost people against BA.4/5 and BQ.1.1, which were prior variants. And so as we talk about these vaccines and we talk about targeting vaccines to particular variants, the reality is these mutations are probably cross-protective and you get antibody responses to prior variants as well as potentially future variants. Next slide. And this is actually showing what happens to future variants. So since XBB 1.5, which the vaccine was developed to, we've had a number of current variants. So EG.5.1, FL.1.5.1, which are probably what's circulating most right now. And you see, again, that you trigger antibody levels to those individuals that are quite high and kind of in the same ballpark as XBB. So very good. And that's hopefully a lot of hope for today in the context of vaccinating your patients, that, you know, even though the variant's not the same, it's pretty close, that you're triggering responses appropriately. And then, you know, on the far right is BA.2.86. Many of you have heard of this. This is a variant that was described initially in Denmark. There's been some cases described globally, a few in Canada. It's not really taken off much, but it's one that's of concern because it's become quite antibody evasive. But just to say, we have data even in that domain that you still see antibody levels that are quite high after vaccination. They're about 8 times higher than pre-vaccination. And so, you know, that they're still, you know, for people that say, well, the variants now are different than the variants the vaccine was developed for, it's actually not that true, that the vaccine is developing immune responses to variants that are current as well as variants that are prior as well. Next slide. So one of the questions that gets asked amongst high-risk individuals is there any benefit for me getting a vaccine? I had COVID recently, I think I'm protected from severe disease moving forward. And for the most part, yes, like there is some protection. I don't think anyone disagrees with that. This is actually data from the bivalent vaccine rollout in Italy that was published in Eurosurveillance. And it looked at additional benefit to a COVID-19 vaccine stratified by either prior infection or when that prior infection was. So if they've ever had a prior infection, so no or yes, and when that prior infection was. And when you look at the sensitivity analysis, which really tried to pick out patients that were hospitalized for COVID, rather than patients that were just hospitalized and had a COVID test after their vaccine, there was an additional 60% benefit in getting the bivalent vaccine as compared to not getting the bivalent vaccine in both a non-infected population, but even an infected population in that sense. So that would suggest that high-risk population, particularly over the age of 60, I think in this trial, would benefit from an additional dose of vaccine. And it's not a trivial number. It's an extra 60% benefit in this population. The one caveat in this trial, and one thing that is incorporated into that NACI advice, which is important, is that when you look actually at 6 months, so 17 to 26 weeks, the benefits are fairly small for vaccination after an infection under that 6-month point. So that NACI guidance of 6 months, for the most part, should be followed for patients. Obviously, there's individual circumstances, but there is actually good data to suggest that doing it a little bit earlier may not be harmful, but there probably is of limited benefit in that sense. Next slide. So a lot of questions about the new intervals around the vaccines, and just recognizing that this is a little bit different than prior vaccination. So this is from Ontario Health as well as the monograph for Pfizer. So in terms of boosters, it's pretty similar for everyone in the context that it's just another dose. In that sense. And then again, the doses of 25 micrograms and 50 micrograms being different between the two age groups, under 12 and over 12. The unvaccinated advice is a little bit tricky. And again, especially as there are some individuals, particularly young individuals, that are coming forward for their first vaccine during this campaign. So for the first time, these vaccines are authorized for primary series. So that's a difference. And there's likely going to be deprioritization of the original vaccine given the manufacturing issues. And then the second thing is that there's a little bit of a different spin on vaccination here. So in the kids under 5 years, the vaccination is given as the same kind of primary series. So 2 doses of vaccine in the Moderna schedule, or 3 doses of vaccine in the Pfizer schedule, and a booster that's a single dose in that sense. The individuals over the age of 5, so 5 to 11 years old, and 12 plus years old, the recommendation for a primary series is a single dose of vaccine. And some may ask, well, why? It's different in certain groups. And the reality is that people over the age of 5 have likely been infected already. And so they probably have gotten their first and probably second dose with that prior infection. And so really we are just finishing the series with that extra dose to really optimize them. The reason that we're still doing the full series for the under 5-year-olds is there is actually a likelihood some of them are born during the pandemic. Some of them are fairly naive. And so again, they're not, there may not have been prior infected, and the better choice is to actually finish their vaccinations appropriately. And again, the difference between the Pfizer and the Moderna vaccine is dosing. So it's 3 doses for under 5, 2 doses for Moderna. The booster is again a different dose. And the one last caveat from NACI is that especially if you are vaccinating 12 to 29-year-old populations where there is a slightly higher risk of myocarditis, particularly in men, if you're doing their primary series, not their booster, but their primary series, then you should consider using the Pfizer vaccine as the preferred vaccine. Next slide. So moving on to RSV vaccines, these are obviously new and coming to the shelves. Next slide. So firstly, I just want to remind people that RSV is actually a serious illness in hospital. And when you look at financial as well as outcome-based data, it actually is in the same ballpark as influenza at every given season. We talk a lot about influenza because the fact that we have influenza vaccines and therapeutics, and so we do a big campaign and raise public awareness, but RSV has been kind of a silent killer in the background because we've had nothing to offer people. There's been a bit of a shrug to say that, it's an acceptable kind of respiratory viral illness. And so, we obviously know this is a virus of kids. So when you look at hospitalizations, 70% of all hospitalizations in Ontario are children. That's true. Only 22% are in those over the age of 65. And just continue the slide along here. You want to kick? Perfect. When you look actually at what happens to those individuals, so yes, children at the hospital, it's quite disconcerting. They need oxygen, they need support. But the vast majority of children survive and leave that hospital unscathed. RSV in adults is actually a fatal outcome in many individuals. So, Ontario data and even American data suggesting it up to like 1 in 8, 1 in 9, 1 in 10 die during that hospitalization of complications of RSV. And that really makes up 85% of the RSV deaths in the province are those over the age of 65. Very few RSV deaths are in children. Next slide. And there's actually a healthcare cost to this. So this is actually data from Alberta that is fairly recent, actually, looking at individual healthcare costs from RSV infection. And looking at their costs in the first 30 days after an RSV positive diagnosis, and recognizing this is a virus that's largely diagnosed in healthcare. It's rarely diagnosed in the community because of the fact that swabs are not available and turnaround times are not clinically relevant. But just to say, an RSV hospitalization costs about $12,700 in the first 30 days. And if you get kind of older, it's even more than that. Paradoxically, the costs are less than 80-year-olds, and that has to do with the fact that they don't make it through a long hospitalization, and so some of that cost is censored very early. When you look at 365-day costs after that hospitalization, it is $40,000 and quite high in 65 to 79-year-olds and 80-plus-year-olds, likely reflecting care needs that come from it and the loss of independence from a serious infection. And inpatient costs are about 70% of this. So, just to say that this is an expensive illness as well to the healthcare system. We're talking about healthcare structuring being very, very difficult in the financial setting, but this is actually a significant cost. And so another issue around appropriate vaccination. Next slide. And so the vaccine is made up of two components. There's the adjuvant on the right, which is the AS01 adjuvant. Many of you recognize this one from the recombinant herpes zoster vaccine, where that's been used as a very successful adjuvant, particularly in older individuals, and causes a fairly decent arm response. This vaccine has about 50% of the adjuvant content as Shingrix. And then we have the antigen. And there's a really long story about how this antigen was made. There was a lot of work in the 60s and 70s around RSV vaccines. When we look at the best antigenic target, it is this fusion protein or F protein in the surface of the virus, similar to the spike protein in COVID-19. It's very conserved. But the issue was the fusion protein, when it's in its natural state, stays in this post-fusion conformation. And that really doesn't allow for a lot of good antibody binding. And it's been the issue when we trialed these vaccines in the 60s and 70s. You really didn't get antibody responses that were protective for patients, and in fact, did not show up as protection in clinical trials. And so they were largely abandoned. Fast forward about 10, 20 years, there is this recognition now that the pre-fusion conformation, so how the virus looks before it binds to cells, is actually the more specific type for antibody binding. And so you have very strong antibody binding pockets, particularly in the surface domain, which are conserved, which is great. And offer a clinical benefit to individuals that to preventing RSV and preventing outcomes from RSV. But there's been a lot of work in the last 10 years in terms of how to lock that protein in this conformation. And that's really what the last step was. Once that was figured out, in the last, I think, publication of this was about 5 years ago, there were 3 vaccines that underwent clinical trials, one of which is this one we're talking about that's approved in Canada. all using the same technology, essentially, of the pre-fusion RSV protein locked into conformation. Next slide. So this is the randomized clinical trial for this vaccine that's approved in Canada. Next slide. It's a bit of a long clinical trial. It's actually ongoing still, but what we're reporting is first season data here. And it's about 15,500 and 12,500 individuals in placebo or vaccine group. The trial was randomized again, actually, in 2002, 2003 to another dose or placebo. And then in season 3, which is ongoing, is now randomized again to another dose versus placebo. And so there are two aims of the trial: one, to see the primary endpoint of what a single dose does in a year, but also to see what happens to people who get multiple doses, i.e. boosters, or only that single dose in the first year. What we're going to report out is the primary endpoint. And then the secondary endpoint, I'll show you some initial data, but it hasn't gone through full data review. It's been an interim data analysis. The only other thing I will mention here is RSV season 1 is 2021-2022. For those of us who reflect back 2 years ago, that was a year where we were still in significant lockdowns, where social distancing was there, where there was significant travel restrictions. And so the baseline circulating RSV rate in the community was actually quite low. We'll still see benefit, which is good, but just to say the number of events is relatively low. And really kind of season 2, season 3 probably reflect a better scenario for what's going forward. And the initial data looks reasonable. Next slide. So these are the inclusion-exclusion criteria. They included those over the age of 60 in the community or long-term care. There weren't enough long-term care individuals to do a full analysis for. And they allowed people with chronic conditions, and about 30 to 40% of people fit the criteria for chronic condition, as long as it had been medically stable. So they had not had significant instability in their illness, including hospitalization or serious complications, but they could be in with things like coronary disease, diabetes, COPD, asthma, etc. The exclusion was immunosuppression. This is pretty common in most vaccine trials to have immunosuppressants or any kind of immunoglobulin component being excluded because it would interfere with vaccine effectiveness in a kind of more naive population. And again, serious or unstable chronic illness was an exclusion criteria. Next slide. So they looked at 3 things. The primary endpoint was lower respiratory tract disease. And I won't go through the entire definition just for the sake of time, but this was the presence of RSV and 2 or more signs or symptoms of moderate to severe RSV. So these were cough, dyspnea, sputum production, kind of those signs of lower respiratory tract infection. And so that was the primary endpoint this trial was powered towards. It showed an 82% protection in that domain. And the FDA criteria for approval of the vaccine was a lower limit confidence interval of greater than 20%. So well above that at 57.9%. I think people, recognize in influenza vaccines, they're important, but we're talking about efficacies of 20 to 60% on any given season. So for respiratory viruses, it's actually quite good. For ARI, this was just defined as, RSV plus a symptom that would be suggestive, mainly upper respiratory tract symptoms. You still see a 71% vaccine efficacy. And when we talk about severe lower respiratory tract disease, so these were people that were tachypnic, that had crackles on examination, that required oxygen, that required a medically attended visit, we see the vaccine efficacy being at 94.1%. Only a single individual developed severe lower respiratory tract disease who had a vaccine. Next slide. When you look at comorbid status, again, amongst those people with cardiorespiratory and metabolic conditions, there were very little events in the RSV arm in the subgroup analysis, so very effective. When we looked at pre-frailty, and that was defined as a walk test with a lag that was abnormal, but not significant to define frailty, we still see a benefit. And then a 70, 79-year-old population, we still see a benefit there in the older populations. There were 80-plus-year-olds that were enrolled, but again, the numbers were in the low hundreds, and so very, very not enough to actually describe a difference statistically. Next slide. One of the questions, so RSV is really has 2 subtypes that co-circulate, RSV-A and RSV-B. The fusion protein is actually quite conserved between the 2. So the vaccine actually uses the RSV-A fusion protein. I will mention this because the Pfizer vaccine, which is going through approval now, uses both an RSV-A and RSV-B fusion protein, and so a bivalent modality. But just to recognize, in this trial, they looked specifically for RSV-A and RSV-B, and there was no difference between the two. And so the protection was seen both for RSV-A and B, meaning that there would be not a lack of protection for the RSV-B fusion protein. Next slide. So this is the early season 2 data that was that's in MMWR and goes through. And so this is looking at season 1 and season 2 data combined. You do see that season 2 data tightens up the confidence interval a little bit, and that really reflects a larger event size. And so when we look at lower respiratory tract disease and medically attended lower respiratory tract disease, you still see combined season 1 and season 2 data being about 77%. So still positive. The other point, as I talked about, is that there are now individuals with 2 versus 1 versus 0 vaccines. And when we looked at 2 versus 1, the vaccine efficacy at medically attended lower respiratory tract disease was actually exactly the same and not statistically different. And so for now, there is no recommendation for a booster. That we do have some data suggesting 2 is the same as 1 vaccine and a booster isn't needed. There will be the full 24-month data review of 2022-2023 coming up in the fall. And so we'll get a little bit more information there. But just again, you should be planning right now for a single vaccine rather than an annual vaccine campaign until better data comes forward. Next slide. COVID treatments quickly. A big question that came in through the questions was, who should we be treating? And the best way to show this is Ontario and Quebec data. So I'll display that now. Next slide. So this was Ontario data by Kevin Schwartz's group that looked at OHIP data. It was in that period of April to the fall where providers, like healthcare providers, could prescribe Paxlovid, but before pharmacists could, and kind of where there were stricter criterias. And, again, looking at this, there was a benefit seen across most populations. The biggest benefits and the most statistically significant were those who were over 70, where the number needed to treat was 45. And those who were considered an OST high group. So these were immunosuppressed individuals, multiple comorbidities, lower vaccine status, where they benefited the most. And then people who had less than appropriate vaccination. Now, this is 2022-23 data where vaccines were not the same as currently, but people who were lower on the vaccine scale showed a benefit for getting Paxlovid. Next slide. This is looking at Quebec data and similar kind of data set, similar kind of looking back. And the big ones that stick out here are 70-plus-year-olds, particularly if they are greater than 6 months after their last vaccine, and immunocompromised individuals. Now, they didn't really stratify a lot of comorbid status because they weren't allowed to prescribe for severe comorbidities outside of age. But again, this is really kind of real world data suggesting that over 70 group probably still benefits, particularly if they haven't gotten their bivalent or new monovalent vaccine recently, that they should be considered pretty highly to get Paxlovid. Immunocompromised individuals across all domains, so even if they've been vaccinated recently, should get Paxlovid, and we have good data about even our transplant patients having significant beneficial outcomes from an early treatment. The rest of the population, under 60 with a comorbidity, I think it's an individual discussion. The rate of hospitalization, depending on that clinical status, is relatively low. For people with severe COPD who are 55, maybe there's a better beneficial effect there. But again, I think as you get under that 70-year-old group, particularly under 60, you're probably losing a lot of the benefits, even in a comorbid population that isn't immunocompromised. Still, again, individual decision-making is important and to discuss it with patients in that sense. Next slide. Last thing is IPAC in the office. So people are asking about what to do in the office, particularly as things are getting a bit worse from COVID community rates. These are guidances for acute care from the Public Health Ontario office, and just they're not an unreasonable overlay to what should be done in primary care. In high-risk periods, and high-risk periods are defined as lots of outbreaks. I think that's been shown, particularly in long-term care right now. There are a significant number of outbreaks. Hospitalizations and ICU admissions. There are hospitalizations. ICU admissions are not necessarily going up that much, but hospitalizations have. Again, a lot of that may be nosocomial transmission as compared to actual community-based admissions. And then community transmission, higher increasing, would also be a big piece, and I think that's what we're seeing today. So kind of 2 of the 3 criteria are pretty much there in that sense. At that point, the recommendation is healthcare masking for direct patient care and for inpatient clinical areas. Consider it for outpatient clinical care, which I think is pretty much the scenario here. And then for patient masking, recommend when ambulatory, recommend visitors as well, especially in clinical areas. So you can take that in that context of, in the considerations of the situation we're in, it may be worth it to at least as a provider be masking and your staff. And the patient and visitor piece, we've seen a lot of hospitals re-invoke mask mandates for staff. The patient and visitor piece, again, based on that ability to get people masking without conflict, should be a strong recommendation at the minimum now, and considerations to align with acute care in that sense. Next slide. Return to work is the other in the last slide here. So ideally, we isolate people for 10 days and a minimum of 5. Look, I think we understand we are in healthcare staffing crises and we had to return people to work early. 10 days is not sustainable by the current healthcare system, especially in acute care. And so our typical return to work guidance for acute care is 24 hours fevers free, symptoms improving. If there's GI symptoms, we have 48 hours. We recognize those folks are still contagious. And so, we ask them to wear a well-fitted mask at all time, provide a safe environment, particularly for unmasking. So in non-clinical areas, they eat by themselves, they eat outdoors, that they can do it in isolation safely. And I think, again, we recognize that people may not be tested for COVID, and even with some of the late presentations of rapid tests, that you may not have a COVID diagnosis. And so really this consideration, particularly the return to work consideration early, should be probably the guidance for most ARI. So your staff that have an ARI, even though they don't think it's COVID, the tests are negative, you at least at the minimum, if you're bringing them back to work when they're improving, is put them in a mask, provide a safe environment for them to unmask, and then do that for the full 10 days in the context. Next slide. And I think that's me.
Perfect. All right, great. So if we can just take down the slide deck to do a little bit of Q&A here. So thank you so much for that presentation, Zain. I think you covered so many different elements, from talking about the effective new vaccines and how they target the variants that we're currently seeing, as well as some previous variants, the benefits of the RSV vaccine, especially for the elderly population, both from a health and from a cost perspective. Talking about Paxlovid and the fact that there seems to be benefit, particularly in the elderly population as well. And then some really helpful practical guidance on what to do in terms of managing our staff and our offices as well. So thank you for that. I'm going to ask a few questions before we turn over to our next speaker, just because I did see some interesting questions here. So the first question is about the rapid antigen tests. So the currently available rapid antigen tests, so let's say the ones in the green boxes, do they actually work to detect the latest variant of COVID circulating in Ontario?
Yeah, it's a great question. So first of all, make sure that they're in date, and there is actually some extensions of date that have been out there. So for folks that want to look at them, they're online. You can look up whether or not their product expiry is being extended. Most of them have been. The answer is yes. Now, there's a publication on this a few days ago, and the phenomenon noted is that as people have been more infected and or been vaccinated, symptom onset is actually much earlier than kind of high viral loads. So people start getting sick earlier, which means that, initially when people did a rapid test, their highest viral load is usually when they're symptomatic. And that would usually test positive. So I have symptoms, I did a test, it's positive. That means I have COVID. The problem is now symptoms being early, tests, your peak viral load is actually 4 days after symptom onset. And so that no, it's not that rapid tests aren't working. It's the window to pick up COVID in a rapid test viral load is a bit later than pre-vaccination, Omicron, et cetera. And so for folks, if they're going to use rapid tests, they still work, but you should be serially testing and probably till about day 4 of symptoms to rule things out, basically.
And I guess on that note of serial testing, can rapid antigen tests also be used to determine if someone's no longer contagious anymore once it converts to negative?
Yeah, absolutely. So that data is still there. I mean, after day 10, it's a little bit tricky because, you know, it's not clear how much how much virus is still around, even if it's triggering a rapid test, how much, you know, that's infectivity. And when you look at culture studies, it's a bit controversial, but certainly up to day 10, there's good correlation between those rapid tests and infectivity.
Thank you. So another question for you is with regards to like the order of importance and interval for the different vaccines. So let's say we're thinking about a 65-year-old in our practice, and we're thinking about the COVID booster, the RSV vaccine, the flu shot, Prevnar 20. Maybe you want to throw Shingrix in there as well too. Any thoughts around like how we should be prioritizing these different vaccines given our situation?
No, it's a great question, and Tdap as well, throw in there as well. But anyways, so co-administration, at least for COVID and flu, is very well shown. And so, you know, you can obviously give those two together. They're probably good ones to give right now. Last year's flu season started early, and, you know, it doesn't look like it thankfully has started early this year, although Thanksgiving is usually when we start seeing it. And so it's kind of getting there. We haven't seen a lot, thankfully. So we'll hopefully that the timing is appropriate. RSV season, again, it's not clear when it's going to start. Last year, it started early with all the differences post-pandemic, but this year it might be closer to normal based on some Australian data. So you'd have a little bit of time there, but it's also a first vaccine. So, you know, you need time for people to get their immunity up. The co-administration piece for RSV is a bit controversial. So in the US, ACIP has said you can co-administer it. There's actually safety and immunogenicity data for RSV flu co-administration. The Ontario Immunization Advisory Council that reports to Public Health Ontario said, you know, you might want to consider the 2-week wait after an RSV vaccine just to separate adverse event profiles. It's risk and benefit for those patients. So long-term care, for example, it might be worth it to get everything done now because of the fact that respiratory viruses, when they circulate in long-term care, have a huge environmental risk. But, you know, the community dweller, you know, COVID is probably the one to get in now, considering there's a lot of COVID around. Flu could be given with COVID. And then if people, you know, in that risk and benefit discussion want to do an RSV vaccine with it, then they could do all three, otherwise separate it out by a couple of weeks. You know, Prevnar and Shingrix are important too, but, you know, in the context of people not wanting a ton of vaccines all at once, you may want to separate them out. If someone's really willing to get all of them at once, though, I think you still have some reasonable rationale to give it, especially if you're going to lose them for the next 6 months. So again, individual circumstances. COVID is probably the big one today because there's COVID around today, but flu and RSV should probably be there sooner rather than later for the most part.
And my understanding too is for the RSV vaccine, that one has to be administered separately, right?
Like that OAIC guidance was similar to when COVID vaccines came out to wait 2 weeks. There's nothing from a safety standpoint. It's really just new vaccine. We want to monitor the adverse event profile and not misattribute it to multiple vaccine products. There still is some guidance that if it benefits the patients more than not to not have that 2-week wait, that you can do it and just monitor adverse event profiles carefully. That's really it. There's not a safety issue. It's just that being careful while a new vaccine comes on the market.
Right, thank you. So I see, Liz, you're on the screen as well too, and I think because some of these questions pertain a bit to rollout of vaccines, and I know we'll be hearing from you shortly, but I'll throw one at you right now, which is about when will these new COVID vaccines be available across Ontario? Any updates on that?
Yeah, for sure. So the updated vaccines, the Moderna one has already started in terms of giving it to the very highest risk. So long-term care in the hospitals, and actually some public health units also have already started giving it for the very highest risk. There's a big shipment of Pfizer that's expected. So expect sort of next week that we're going to start to see more availability, particularly in pharmacies. So that's important around, I saw there were some questions around like, what about healthcare workers? And so yes, healthcare workers, you're in the higher risk groups. So, you know, more of this updated vaccine available to high risk groups starting next week. And general population for the COVID vaccine, we're tracking end of October is what we're looking at for general population, either through pharmacy or public health units, or you if you're doing it in your office. And Zain, you jump in if you know more, if you have other details on this. But what I have understood also is influenza vaccine around October 30th is the date that they're looking at for availability for general population, and RSV also very end of October right now. So that's when it's available. And the RSV vaccine is was mentioned is covered through the public purse for the very highest risk over 60 in congregate settings. So it's like people in long-term care. Everybody else has to pay. And my understanding is you need a prescription, just like for other private purchase vaccines that go to pharmacies. And that will, and there's a whole equity piece on that I can see has also been raised in the conversation, but that's tracking very end of October as well in terms of when it will be available through pharmacy.
So the one thing I will say is there is work being done in the background for primary pharmacy prescribing, which is great, and hopefully that will be there. Let's see. Other provinces have brought that in place. So BC and Alberta have had primary pharmacy prescribing right off the top. The other thing is there is vaccine in pharmacies for RSV now. So if people are interested, they can get it. For people that have, I believe, that have accounts with GSK, that they can get it too through their offices. So that is, and I know there are injectors out there. I've talked to a few folks that have gotten their vaccines already.
Okay, perfect. Good. Thanks, Zain.
Thank you. Thanks for that. So Zain, I'll give you one more question because this is one that comes up quite a bit, which is about rebound COVID after treatment with Paxlovid. So the question talks about the fact that they had a patient that tested negative for a couple of days after Paxlovid and then eventually converted back to positive. And is there any evidence for a second course of Paxlovid or a longer course of 10 days for Paxlovid?
So good question. This is an issue right off the bat. So when you look at rebound, it actually is a phenomenon that happens in people that don't get Paxlovid, although the Paxlovid folks probably get more symptomatic. There is no guidance yet, but the many international bodies say don't treat again, and recognizing that the rebound phenomenon, people actually do make a very good immune response. They're still symptomatic, but there's not really good data suggesting longer or recurrent treatment changes the trajectory. And in fact, when you look at rebound cases, the risk of hospitalization is well less than 1%. So, the bottom line is they still benefit from their initial COVID Paxlovid treatment. That sucks that they feel worse again, but again, the risk of hospitalization remains very low. And right now there are a couple of small clinical trials ongoing that are looking at this. So again, we may get more data over the next few months and years in that sense. But for now, just one course of treatment, 5 days is the standard for everyone, basically.
And if I can throw in one kind of additional follow-up to that is around long COVID. Is there, any changes around the evidence around Paxlovid preventing long COVID?
Yeah, I mean, again, it's a good question. It's being looked at in ongoing trials now. There was one retrospective study that was done when Paxlovid first came out in 2022 that was looking at the VA hospitals in the United States that showed a 6-month benefit in terms of certain domains like cardiovascular and respiratory domains. I think a lot of that is driven by the fact that Paxlovid kept those folks out of hospital. And so keeping those folks out of hospital has benefits for their post-acute symptoms. For kind of the young person who is not at risk of high risk of hospitalization and, is considering Paxlovid for long COVID prevention, that data is not there, and right now would not be an indication in that sense.
Thank you for that, and thanks for answering all those questions. So I'm going to turn things over next to Dr. Kumanan to give us some really exciting updates from the OCFP. Over to you.
Thanks. I have to say I do love being able to share good news. So happy to be doing so today. We can probably just jump to the next slide. So I wanted to take a few moments to review something that the OCFP shared last week. And this was in follow-up to some of our work with our partners at the SGFP, as well as our work with the CPSO. You probably recall that we did a member survey earlier this year that was focused on the administrative burden. And what we heard very clearly from family physicians across Ontario is that other parts of the system were placing unnecessary and inappropriate burden back onto you in your practices. We also heard that in general, there seemed to be a lack of clarity in terms of sort of roles and responsibilities between referring and consulting physicians, and that there was essentially just some confusion in terms of who should be doing what, particularly in specific circumstances. So we heard that you would like clarification on the CPSO policies, and so we took action to seek this clarification. And I was really pleased to see the CPSO recently published an updated advice to profession on their continuity of care policies. So just to note that these updates essentially are clarifying the existing policy expectations, including clarifying roles and responsibilities in very specific scenarios. So I'll go through a couple of those. The first that I think many of us are now aware, so except in specified circumstances, any physician who determines that a test is needed is ultimately responsible for ordering that test, tracking the results, and managing any follow-up that stems from that test. That was one of the points of clarification. The second was that when a family physician has been copied on tests, we don't in fact have any additional responsibility to follow up on those results, except in cases where we believe that it is a clinically significant test result that has not been followed up on. And then finally, in terms of referrals, there was clarification that consulting physicians can support referring physicians by accepting consultation requests when possible, even if there are minor issues with the request. So I think a common example that we see is that we've used the wrong form or an outdated form. And so really to try to save us all time and not waste capacity across the system, I think they're looking at sort of streamlining that as much as possible. If you would like more information, you can actually see the latest e-dialogue for more details. And I will just say again, really happy to see these areas being clarified. I think it will make a big difference for us in our day-to-day work as family physicians. Okay, next slide. So just a couple of other things. You may have heard that last week, Minister Jones announced that 12 initial OHTs will be supported to accelerate OHT progress. And at that time, our colleagues at Ontario Health highlighted that primary care networks will be a necessary building block in that process. You likely recall that the OCFP, as well as AFTO and the SGFP, have been advocating for quite some time for PCNs and in support of PCNs in a number of different ways. We had pulled together a PCN blueprint that was developed in partnership between the OCFP, AFTO, and the SGFP. And at the OCFP, we've also included primary care networks in our policy document, our plan of action, and that was developed in partnership with the SGFP. And we've also had regular discussions with government on the importance of primary care networks. So ultimately, I think we know that primary care networks will provide family physicians with an important mechanism by which we can support one another, as well as sort of gain access to tools and resources that will support us in practice. So really looking forward to seeing the development of PCNs across Ontario. And then just on the second part of the slide, you'll see notes about our Leadership Academy. So the OCFP, in partnership with the Rotman School of Management, we are now accepting applications for our second cohort of our Family Physician Leadership Academy. We definitely saw lots of interest in the first group, and this second cohort will run from February 2024 until the end of 2024. It will be a combination of both virtual and in-person learning. And really, this Leadership Academy is designed to help equip family physician leaders with tools and knowledge that you'll need to help navigate our very complex healthcare system, to champion patient-centered care and to drive innovation in primary care. So if you are interested, there is more information on the OCFP website. And I think just important to make the connection that we know we're going to need strong primary care leadership in primary care networks. And so really important to see family physicians engage in this. Okay, next slide. And just a quick reminder, I think our team had put this in the chat as we're heading into respiratory season. We've pulled together a number of resources at the OCFP to help both you in your practice, as well as resources that you can direct your patients to. So you'll find those on our website, as well as stayhealthyontario.ca. Great, next slide.
Awesome. Thank you so much for that, Mekalai. So for the audience, if you have questions or comments for Mekalai, please put them in the Q&A in the chat, and she'll be typing back responses. And so next, I'm pleased to turn things over to you, Dr. Muggah.
Thanks so much. And Mekalai, just to let you know, we're having conversations in our own practice about the announcement around the CPSO clarification. So I know this is a welcome information and guidance coming out on that. So really appreciate the OCFP's work. So a couple of pieces around sort of the system level parts of the fall and how it relates to everything that we do in our offices. So as you all feel, given the workload, but has also been something we're seeing in the data, the volume of our visits in primary care have increased and are up at all the pre-pandemic levels. And parts of the work that we're doing on cancer screening, for example, are now exceeding pre-pandemic levels. We're at sort of something like 110% for cancer screening and breast cancer screening. So, you know, we certainly know how hard everybody is working, and of course, the increased demand that's now going to come through the fall. So there's no question that the work that you will do to prevent and treat and test patients for all the host of respiratory illnesses is going to be the cornerstone of keeping people healthy in their community and out of hospital. So just enormous acknowledgement from Ontario Health and from me personally, and certainly this is the work that I'm doing in my office right now. So so thank you for that and what you are doing every day. From the Ontario Health side, there has been work on some what we call an operational direction. So this will be a system-wide messaging that goes out to hospital long-term care and primary care about the fall respiratory season. So that is to come out shortly. And then we will follow with our from within our primary care program with resources around respiratory illness. And all of the pieces that we've talked about here in terms of having that kind of at your fingertips. So that will come. It's making its way through translation and approvals, et cetera. So hopefully a helpful addition to what you've been receiving from others like the OCFP and the OMA on you know, collecting those resources together. So next slide. So just some of the specific pieces I'll call out around Ontario Health's role. So if you just go to the next slide. So this is, I think you're aware of Health 811, and kind of interesting as someone now who's joined Ontario Health to take a look at the data around the use of Health 811, which is this 24/7 service for patients. And it has not only the phone where you get a nurse to speak to, but it also has this online chat, and then it has the symptom checker as well. And so I asked them for the call usage and sort of volume of usage across the province, just because I was interested and thought you might be as well. So in the month of August, there were over 54,000 calls to Health 811, 8,000 through additional online chats that came in from the public, and somewhere around 7,000 through this symptom checker over the 3-month period, sort of June, July, August. So that continues to be available to your patients, and you know, we're continuing to update the website to make sure that it's patient friendly and enabling this point of access for patients to get the information that they need, particularly around this time when we know you know, there's going to be the increased demand for support from patients around respiratory illness. The next slide has it's the information about the regional virtual urgent care programs. So, I think all of us know that the most important care that a patient can receive is the care in the office of the family doctor who knows them well. So it's that comprehensive continuity of care. At the same time, we recognize that there may be patients who don't have a family physician or a nurse practitioner providing comprehensive primary care or any primary care. And so these are now each region has a virtual urgent care. It's run by an NP, and with an attempt to kind of provide a little bit more standardization of that service across the province. So this is just been rolled out over the summer. There will be an evaluation to kind of take a look at how's this working, how do we integrate it, who's using it, but just so you know, as another option for care for your patients and for unattached patients as well. Next slide. So the portal is the provincial portal, still open in terms of getting you your PPE. It's also the way to get your rapid antigen test. So this is a service that's now run through Ontario Health. So those are the links there that you can use. So next slide. So I think Zain maybe referenced this. We've updated all of our information around COVID treatment. There weren't major updates around that. I mean, things like Evusheld no longer being recommended, but just so you know, this is information that's available on the web. The links are here. Some of the practical stuff that you need around the remdesivir, like the referral forms and the processes for that. So this is all available online. And I won't go through the specifics around the treatment. So I wanted to call out this as well. So one of the things that we are doing in our provincial program is obviously trying to start to provide that guidance and over the province as a whole around the directionality of primary care and to support these efforts for increased access to team-based care, the investments around the organization of primary care at the level of the OHTs. And there was an announcement about that just recently around the accelerating 12 OHTs in particular. And a part of that will be to ensure we strengthen the primary care as a foundation of the OHTs. But I really did want to call out the leadership in each of our regions. So these are the column on the right are our leads for the regional primary care leads in each of the regions. And I'm actually just seeing a very important omission here. So in Toronto, it's Dr. Danielle Martin, but it's also Dr. Catherine Yu. So we will update this slide. So I will mention that and call her out specifically because is an omission on this slide. But these are your leads. They work directly with the regions to support the engagement of communication with primary care in those regions, and also to elevate to me and to our program provincially what are the priorities and collectively look at strategies that could be implemented provincially. So under the contact list there, those are the vice presidents clinical in each of those regions as well. So just wanted to call that out, and my gratitude to all of these people. Some of these names may be familiar to you. And if they aren't, then I'm glad you're seeing them here as well. So, okay, so that I think is my last slide, and happy to, this is my email. So if you ever have any questions, please do feel free to just reach out to me. It's a pretty straightforward email, and always happy to hear from you. And hand it back to you, Ali.
Perfect. Well, thank you so much for those remarks. And I just want to also acknowledge several of those leaders are even on our COP today. So thank you all so much for all the leadership that you do on behalf of all of us and for the community. And so in terms of questions for you, Liz, really there's some here around the rollout. So we'd appreciate if there is some perspective you can provide on that. So we heard from Zain about, the economic arguments around the RSV vaccine, as well as the evidence behind it. Yet, it's still something that's quite restrictive in terms of who it's available for. So we were wondering, like, what from the Ontario Health perspective can you share in terms of what went into the decisions regarding the RSV vaccine and its coverage?
Yeah, I have to say the decisions around the RSV vaccine and which populations would get it were with the ministry. So I don't have a lot of information. I think that, I suspect they got a lot of guidance from experts, and maybe Zain can weigh in if he knows where that came from in terms of who it should go to. I think there was, so I don't know. I absolutely acknowledge it's the first year of this vaccine. We know that it's effective. Would it be better if it was available to everybody and not with this cost? I mean, it seems to me that that's what the evidence shows. I expect it's a little bit about, I don't know. I'm not sure. I don't know if it's probably a combination of what funding was available for it and some sense of a sort of phased rollout to a full provincial program. But Zain may have a bit more line of sight on that if he was involved.
I'm not involved, but just in prior vaccine decision making, I mean, we know this is not abnormal that a vaccine comes to the market and it takes years before it's publicly funded, and even then it's for a particular group. I mean, Shingrix, the clinical trials came out in like 2013, and we just got public funding, I think, a couple of years ago for certain groups, right? So just to say that that's not an abnormal process, it often takes a NACI guidance document to at least start that discussion, as they do kind of the pharmacoeconomics. And that's not even available and probably won't be till next year. So, I think, again, the Ontario government actually bought that supply. That's the only provincial government I know of across the country that has actually done something in terms of a provincial access program. So, it'd be ideal if it was funded, but the reality is most vaccines aren't when they come out of the gate outside of COVID and influenza.
For sure.
And I think
yeah, go on.
I was just going to say, I think historically in, Ontario, not every province has a universal influenza vaccine, for example, for everybody. So, I mean, one hopes that with the work of probably the combination of, public health leaders, our infectious disease leaders, advocacy in Ontario, we can continue to encourage towards an equitable approach to this vaccine as well. So, I mean, those are maybe some heartening parts of, sort of what, if we base future on the best way to kind of guess what might happen in the future is what's happened in the past. So,
yeah, that's true. And I mean, I guess, a similar kind of consideration too is like what's happening right now with Prevnar 20, right? New vaccine that's come out, NACI guidance, but, still not yet at that place where we have it, fully publicly funded or available. And I guess that feeds well into the next question is, have there been any updates on that front, like with Prevnar 20 specifically?
Yeah, I don't have any updates on that. And I can see Zain is shaking his head as well. So
no, I mean, it's a great counter example in the sense it's now the recommended vaccine probably for the naive individual and even for updated vaccines for many populations, but it is not publicly health funded in that sense.
Okay, and then in terms of the other questions here. So there was a question, and I'll throw it back to you, Zain, about serious adverse reactions to the RSV vaccine. And I know you had brought up sort of a risk-benefit discussion. I was wondering if you could maybe talk to us a bit more about what you might discuss with a patient if you were having that risk-benefit discussion.
Yeah, absolutely. So, yes, it's a new vaccine, and that's an important piece. There does need to be post-marketing surveillance. In terms of adverse reactions in the clinical trials, they were actually pretty similar to Shingrix. Not surprising that it's the Shingrix adjuvant. So sore arms, swelling, redness, fever, malaise, typically 48 to 72 hours of symptoms, resolve spontaneously. SAEs were similar between placebo and vaccine. It's 12,500 individuals. And so we also can tell patients, look, up till 1 in 10,000, we probably can get a good sense of adverse event profile. In a 1 in 100,000, 1 in a million population, you probably didn't have the power to detect it. And so there may be adverse events that show up in post-marketing surveillance, but as long as you're giving it to high-risk patients, you're talking about the benefits here that we're actually seeing that were statistically significant in the trial. The only other point would be there is one in the monograph. There are 2 cases of Guillain-Barré syndrome through all the clinical trials that were done with this vaccine, or one was ADM, but one of them was with someone that had also gotten a flu vaccine along with their RSV vaccine, so I wasn't sure which was attributed to. So probably maybe one case of Guillain-Barré syndrome, which, you know, as you weigh that, is actually probably the baseline rate in the population. So it's hard to say what exactly that means. It's again a signal that needs to be monitored post-marketing, but you know, in the context, we have surveillance post-marketing, we have AFI, we have all these other portals, so that's actually still an important part of ongoing vaccine rollout in that sense.
Thanks so much for that. I'll end with one final question here, which is around gatherings. You know, this is something that, especially as we go into the long weekend, you know, with indoor gatherings, or, you know, let's say something like group psychotherapy, you know, is that still safe to gather indoors unmasked, or would we recommend masking and distancing at this point?
Look, there's nothing to say that wearing a mask isn't a benefit for certain individuals and for layers of protection, similar to making sure people are vaccinated, up to date, etc. People want to use it, they can use it. I think, you know, again, if you want to prevent COVID, if you have vulnerable family members in that space, it's not a bad idea. But I think you leave it up to people to make that decision, and you know, and respect their decision making, I guess, in that sense. But you know, the indoor environments, and there's lots of COVID in the outdoor in the world right now, so it's not a bad idea.
Perfect. Thanks so much for that. So I'm just going to pull up our slide deck just so we can close the session for today. So if we can just bring the slides back up. Perfect. So just a quick reminder about this service that exists from Scarborough Health Network, the VaxFax Clinic. It's a clinic that offers patients the ability to speak with an expert physician and talk to them about vaccines, including the COVID-19 vaccine, RSV, flu, and other immunizations. They've also expanded to providing counseling for cancer screening or preventative health counseling. So a really great and helpful resource for patients that they can access. So the information will be circulated about this one. Next slide, please. Mekalai, did you want to quickly speak to this?
Yes, thanks. So just a reminder that we have our Family Medicine Summit coming up, 2 live stream days on January 26th, 27th, and registration's now open. You can see the website on the slide there.
Excellent. Next slide. And so with that, I want to thank you all for attending today's session, and for all of the wonderful engagement and for all of your thoughtful questions. The recording and the Q&A will be posted soon, and our next community practice is scheduled for October 27th, so please save the date for that one. And we really value your feedback, so please make sure to fill out the surveys. It gives us a lot of valuable information on how to improve future sessions. And with that, I wish you all a happy Thanksgiving. I hope you have some time to rest, rejuvenate, and celebrate with your loved ones. Take care and have a great weekend.